happy to be here. I know I spoke to you guys, I think 3 years ago. So I'm glad to be back and talk about our journey with Fabry's disease with you. So I'll I'll stop. Let me just close this and open my presentation and share the screen. Okay. Let's see how this works here. So, okay. Okay, so I should put it in presentation mode.
Yeah, I can't see it yet. Are you in? You're in share screen.
Yeah, I have to do that next.
Okay, good. Okay.
Yeah. Share screen. Good. Can you? Yeah. Can you see me now?
It looks like it's just about to load. Yep, there we go. Perfect.
Okay, you guys are good?
Yes.
Okay, great. So I'm Gavin Oudit. I'm a cardiologist, clinician scientist here at the Mass in Edmonton. I started here 12 years ago from Toronto, and in my final year as a fellow in cardiology there, I saw my first case of Fabry's disease, a young man who unfortunately died from Fabry's disease that was unrecognized. And we only got his results back 3 days after he passed away. So it was a misdiagnosis. So that really motivated me to do more for patients with Fabry's disease. So when coincidentally, I also met Anil Khan the year before we started our staff position. So he was coming from McMaster to Calgary, and I was coming from Toronto to Edmonton. So we actually connected, and we decided to do this together. So I think a lot of the work we'll show you here is in collaboration with our colleagues in Calgary and at Libin, and Anil Khan in the metabolic clinic. Okay, so it's really a Alberta-wide collaboration. It's really a celebration of what you guys have helped us to do. While seeing you and providing care, you've also helped us to understand more about Fabry's disease. So I'm very happy to be talking to you about it today. So that's my introduction. So let me see here, advancing the slide. This is always tricky, isn't it? Yeah, I can't advance my slides.
Are you able to, if you just go to the arrow button, does that work for you?
The arrow button, like where?
Like if you just go to the right.
Yeah. Okay.
There you go. Perfect.
Okay, great. So, and you know what works great, guys? Like the last time, you just stop me. Okay, as we're going along, you have a question, something comes to mind, and just stop me and we can talk about it. Okay, rather than just dealing with everything at the end. So. Perfect. So Fabry's disease, so the heart disease component of this is so important, right? And it's now recognized as the most important driver of how patients with Fabry's disease do. And so this type of cardiomyopathy, this type of heart disease, it's referred to as infiltrative cardiomyopathies. So it's where things accumulate in the heart, okay? So different things can accumulate in the heart. Sarcoidosis is one example. That's where you have these inflammatory regions in the heart. You have amyloidosis. Those are protein fibrils that accumulate in the heart. You have iron overloads when you have too much iron in the heart. You can have too much glycogen in the heart. And with Fabry's disease, of course, it's a lipid that accumulates in the heart, okay? So any type of different things can accumulate in the heart, and that's never a good thing, okay? So when you accumulate in the heart muscle, that leads to cardiomyopathy, and we call these infiltrative cardiomyopathy and Fabry's disease being one example of that, okay? So for the biochemists in the audience, this is a biochemistry slide that shows the enzyme and the substrate of it, okay? So the alpha-galactosidase is a protein that's defective in this disease that leads to accumulation of GB3 and lyso-GB3, okay? And when that lipid accumulates, it injures different parts of the heart, and this explains what type of heart disease patients with Fabry's disease have. So if it accumulates in the muscle cells, the pumping muscle cells, it leads to hypertrophy, okay? And the heart muscle gets very thickened, and it can also be fibrotic, okay? It can accumulate in the conduction system, and it can knock off the electrical properties of the heart. So that's where you may need a pacemaker or a defibrillator. It can also accumulate actually very earlier on in the disease, and this is a fascinating angle. It can accumulate in the microvasculature, okay? So the small blood vessels that takes blood to all your different cells in your heart. So with that condition, you can get things like angina and small infarcts, okay? So these types of changes are, of course, in the heart, but the microvascular changes, of course, is global. So it affects your brain, affects the tummy, it affects the kidneys, and so on, okay? So it is a very important vascular component of the disease that really is systemic. Of course, it affects the heart, okay? So that's sort of most of the way we think about Fabry's disease and the heart. So this is an ECG of one of our colleagues that shows a normal rhythm, but you can see very fancy, all those fancy spikes on the ECG there. Those are very high voltages, okay? So the heart muscle is very thickened, hypertrophy, and you can get all these fancy voltages that are being produced, okay? So that's like a classic example of someone with a hypertrophy. And the thickened heart muscle affects the left side of the heart and also affect the right side of the heart. And so this is where cardiac MRI is so important to assess that. So these are some pretty pictures from someone with Fabry's disease. On the top left there, you see a short axis view of the heart that looks like a donut. And so that is a hypertrophied heart. On the right, you can see a leaky valve. So this patient also had a leaky valve, which can happen. The aortic valve in this patient was leaky. And in the bottom, you can see histological features of Fabry's disease. So on the left, you can see those white circles there. In the pink, that is glycosphingolipid accumulation in the heart, okay? So this patient had a lot of glycosphingolipid in the heart. So this is fairly advanced Fabry's disease. On the bottom right is electron microscopy, and you can see those zebra bodies. People talk about the lamellar deposits. So that is pathognomonic for Fabry's disease. So that is a very important finding. So sometimes we do biopsy, take a little pinch of the heart muscle, and we send it out for histology, and we send it out for EM analysis. Okay, so that's sort of together with the biochemistry and the genetics. This is how we diagnose Fabry's disease. So most of you know about the genetics. Most of you have had the biochemical test. But when it comes to the heart disease, these are the things we use, okay? Cardiac MRI, we use echo. We look at the endomyocardial biopsy and look for glycosphingolipid accumulation and look for these lamellar or zebra bodies. Okay, so how prevalent is Fabry's disease? So this is, again, an ongoing controversy. This, we're told, is a rare disease, less than 1 in 50,000. But the screening studies don't show that. And so these studies now are older. They're at least a decade old. And in 4 different cohorts, and now the Americans have the exact same data from Missouri. So it's about 1 in 3,000 is what they saw. So everyone has looked at this. Large numbers are saying it's a lot more common, okay? So remember, these are newborn screening, and so these are babies that were tested. So what's very important here is what happens to these babies as they age into childhood, into the adolescence and adulthood, okay? To see how many of them actually really have Fabry's disease, or are we just picking this up in newborn screening, okay? So I like to show it because it suggests that the disease, at least biochemically, genetically, might be a lot more common than we think, okay? How many of these babies go into having full-blown or overt Fabry's disease? We're not sure, and that's where the follow-up studies are going to be so critical, okay? But it suggests that the prevalence is a lot more common, okay? And ethnically diverse, okay? So Japanese, Austrian, Taiwanese, Italian, and American cohorts all showing very similar numbers, all right? So that's very interesting. And they gain, This is the data from the Lancet. That was published in Lancet now for about 8 years ago. And in the rare disease screening for lysosomal storage, the Fabry's disease is the most common. Okay, so it is common when you look at the newborn screening. So again, what the implications here, of course, as these babies age is going to be very interesting, and to see what happens to them in adulthood. All right, so it might be a lot more common. And this is important also because the therapies, enzyme replacement therapy and now chaperone therapies, both of those types of therapies really work when you start them early. Okay, I know some of you have had these therapies and have started them later on, and the benefits are less so, are minimal. So really, I think for all of these, both of these therapies that are now clinically available, you really want to start them early. So early diagnosis, early intervention. I think that's a very key message for all types of rare diseases, including Fabry's disease. So I think following these children will be important to understand when they start having Fabry's disease, if they do, and how to manage it. So as we have done here in Alberta, we have kept track of everyone, all our Fabry's patients, and kept track of their outcomes. This is a study from the FOSS, Fabry's Outcome Survey, which is mainly driven by the European group. And what they have shown here is heart disease is the #1 driver of outcomes, okay? So kidney disease is #2. But so the heart is just so important for Fabry's disease. And I think seeing a cardiologist on a regular basis for all of you is just so critical, okay? And I'm happy to be able to provide that care to all of you here in Edmonton. Okay, so the type of heart disease that patients with Fabry's disease have. So LVH, left ventricular hypertrophy, that's the left side of the heart, the big pumping chamber of the heart. So you get thickened heart muscle. The heart muscle doesn't like that lipid accumulation, so it reacts. It reacts with becoming hypertrophic, okay? And when that happens, it doesn't fill properly. So there are two aspects of the heart function here. It has to fill, then it pumps the blood into the rest of the body. So with this type of hypertrophy, your main problem is filling. So you have a filling problem in the heart, okay? So it's not a pumping problem, it's a filling problem. So coupled with that is that you can also have things like valvular insufficiency because the lipid can accumulate the valves. You can get arrhythmias, things like atrial fibrillation, and unfortunately, you can have very serious arrhythmias, ventricular arrhythmias. So luckily, we do not see a lot of that here in Alberta. We're not quite sure. I mean, it may indicate that our patients are so well managed. I'll take credit for that, and it may be maybe the genetics is a bit different. So, but our rates of the bad arrhythmias, the ventricular arrhythmias, is actually quite low in Alberta. So we are going to report on that soon. But atrial fibrillation is common, and that has to be managed and treated. As I said, when you get things infiltrating in the heart, you have conduction problems, and you can block off your conduction. And so that's when you need a pacemaker, okay? Pacemaker or a defibrillator. So I think a number of patients have pacemakers. And again, the endothelium, the microvasculature, the small blood vessels may be affected, and you may get chest pain syndromes, okay? So those are the kinds of things that patients would complain of. So with the LVH and diastolic problems, you get heart failure, okay? So your heart can't fill properly, and then you go into heart failure. The fancy name for it is heart failure with preserved ejection fraction, okay? And that's the type of heart failure that patients with Fabry's disease get. So a combination of different things, arrhythmias and heart failure are the major problems we deal with. This is a study we have done, and many of you were kind enough to be part of this study. We look at echocardiogram. So this is with the ultrasound probe that we put on your chest, and we take fancy images of the heart. And what we've shown here, very nice, pretty color images that patients with Fabry's disease, so the patients on the bottom, you can see has a more desynchronous color. So in the bottom right, you can see all sorts of different color, yellow, red, blue, green. Okay, so that's kind of like a desynchronous kind of muscle pumping there, okay? So what it should look like is what's on the top, okay? So kind of red, maybe a touch of orange in some regions, okay? So just by looking at the color, you can see that patients with Fabry's disease, the muscle isn't moving as well as it should be, okay? So that's called strain analysis, and we were actually one of the first group to show that. So this is an important way of assessing Fabry's disease in the heart, okay? So that's the echo part. One of the early findings with the echo is to suggest that a key gender or sex differences here in heart remodeling. So all of you are expert in Fabry's disease. You all know it's X-linked. So women are carriers. Men, of course, are hemizygotes, but has a full loss of the gene function. Women are carriers, but they can, of course, have the disease because of the X chromosome inactivation. So as you can see on this figure, it's an old study, 20 years old now, but what it shows is that women get less hypertrophy, okay? So women are in the open columns, men are in the darkened columns. So you can see women tend to have more normal or minimal hypertrophy, okay, compared to men. So women remodel their heart differently than men. And we know that not only because this is an X-linked condition, but also in non-X-linked condition, women in general remodel their heart differently than men. Some of that is genetic, some of that is hormonal. Okay, so that's just an important aspect of Fabry's cardiomyopathy that we cannot ignore. So, again, further study with our good colleague Frank Wiedemann have shown that male and female patients remodel their heart differently, and it suggests that in women you can actually get fibrosis actually very earlier on before you get hypertrophy. And so that was not recognized until we started doing MRI in our patients, okay? So fibrosis now has become one of the criterion for enzyme replacement therapy in women and men. So you can actually get the fibrosis very early on without the hypertrophy, okay? And again, just want to highlight in women, in men, you can the alpha galactosidase activity assay is good enough because the levels go so low, you can pick it up. In women, they tend to be low and normal. So women need genetic testing to confirm Fabry's disease. Okay, so that's very important. Again, that is just a product of the Fabry's gene being X-linked. Okay, so women need genetic testing, and men. But men, you can also see the change on the alpha galactosidase, the biochemical test for Fabry's disease. In women, it tends to be normal or low normal. Okay, so that's an important aspect of it being X-linked. Cardiac MRI, we keep coming back to this. It's so important for you guys to have a cardiac MRI, and most of you, I hope all of you have had one. It's a wonderful technique. And what makes it so wonderful and different than an echocardiogram, ultrasound of the heart, is that the cardiac MRI tells you what's going on with the tissue, okay? The ultrasound tells you about how the heart is pumping, how it's filling, how the valves are working, and so on. And that's all great. That's important information to have. But the tissue is what's changing in Fabry's disease. So this is, again, this happened here because of your kind efforts and being part of the study, but it's the first study to show that the T1 values, okay, with cardiac MRI is lowered in patients with Fabry's disease. So this has now become standard imaging protocol for everyone with Fabry's disease. So all over Europe, all over North America, all over in Asian countries now use this. And it's the T1 value that I've shown nicely there, clearly separates out from normal individual. And the T1 is low because of the lipid accumulation in the heart, okay? So it lowers that T1. And so we did that here at the MAS. We also do this also in the Stevenson MRI Center in Calgary. So that's quite impressive that it came from Alberta. And this is just another demonstration of that data, okay, that the T1 values are lowered. You also can get scar on the left panel there. You see that white streak in the muscle, that is fibrosis, okay? So we also pick up fibrosis in the heart, as I've mentioned, but also low T1 values where there is no fibrosis. Okay, so a very important part of checking how your heart is doing when you have Fabry's disease is really looking at using the cardiac MRI, and it's now standard, accepted standard of practice for everyone to have a cardiac MRI and for you to follow the cardiac MRI. Okay?
Yeah. Is T1 mapping available for all of Canada?
Well, you know, of our colleagues in out east might struggle a bit with availability of MRI, but certainly in BC, Alberta, Saskatchewan, and in Manitoba, I suspect you have. Saskatchewan might struggle. Ontario has it. Quebec has it. You know, I think some of our colleagues in out east might struggle with having that, right? So, but more and more it's becoming available. The protocol is there. Actually, one of our colleagues here wrote the protocol to measure T1, and Siemens, the Siemens system now has it all, so it can easily be done. Of course, if you don't have that fancy cardiac MRI, an echocardiogram ultrasound of the heart is a good substitute. Okay, but it's not as good as the cardiac MRI. Because the cardiac MRI may show you things very earlier on in disease. And why is that important? It's important because that's when enzyme replacement therapy makes a difference. That's when chaperone therapy make a difference. Not when your heart is very hypertrophy and fibrotic. Okay, you have missed the window of opportunity, the window of therapeutic opportunity to reverse this disease. And we have seen the disease reverse. We have seen Fabry's cardiomyopathy reverse. We have seen it stabilize. But there are patients that struggle with this. Even on enzyme replacement therapy are patients that start the therapy when the disease was very advanced. Okay, so that's a key take-home message. You know, we got to get on top of the diagnosis, make it, and then start therapy when appropriate. Hopefully sooner rather than later. All right. So the microvasculature, so important. A number of you complain of microvascular angina, so sort of chest pain. You know, the big arteries in the heart are normal, and it's just small vessels. It's the tiny vessels that takes the blood to the cells, the microvasculature that's affected. So these are beautiful images there in the bottom. So light microscopy, electron microscopy showing how these small vessels are completely blocked off, okay, with glycosphingolipid accumulation and secondary hypertrophy of the vessel. So you lose the lumen, right? So it's like a hose, a water hose that someone has stepped on, okay? It just can't take blood to the heart muscle anymore. So that's what you get with Fabry's disease. So the angina is a big concern, especially when the disease gets more advanced, okay? It's less of a concern earlier on in the disease. Again, that is just more of the same picture. And in fact, when this happens, you may have chest pain. You may actually go into the emergency department and you may be told that you have a heart attack, right? And you have a heart attack. It's a small heart attack. The micro heart attacks. And your troponin, which is a marker of muscle damage, is often elevated, to very mildly elevated in patients with Fabry's disease that are having chest pain, okay? And in the bottom there, you can see that whole meshwork. Can everyone see that? The mesh of those small, beautiful vessels, right? That is what's affected in Fabry's disease. So you do not get a big blockage that blocked off a big part of the heart muscle, but that if you start affecting those small vessels, you're going to start getting angina and start having very, very small heart attacks. So over time, that is not good. Okay, so the microvascular angina is a big part of the story. So the other thing we've been trying to look at is what are the changes in blood parameters that we can keep track of that might tell us new things about Fabry's disease, that can allow us to monitor you guys better and to gain further insight into Fabry's disease. So this is a study again from Alberta with our colleagues from Calgary, and with Michael West also from Halifax. He has provided some plasma samples. And what we show here is that patients with Fabry's disease have elevated BNP. So these are markers of myocardial injury and fibrosis. Okay, so collecting one in particular here are elevated. The lyso-Gb3, which is a well-known marker of Fabry disease, also elevated, and so is troponin T. So these with Fabry disease, you are losing some cardiomyocytes over time, and we can pick that up now in the blood samples. So that is going to become a very relatively easy and cheap method of keeping track of what's happening with Fabry disease as it affects the heart. Okay, so biomarkers, and this is now becoming a big push in Fabry disease. All right, so that's.
May I ask a question?
Yeah, absolutely.
Hi, my name is Lori. I'm from Richmond Hill, Ontario.
Yeah.
With respect to strenuous exercise, how does that affect the heart in the way of troponin levels, CK levels in the body as well? Like my family in particular, my son and I, when we have done what someone would say is normal exercise, it's strenuous to us, and it's been shown in our blood work that CK and troponin levels do go up from the exercise. How dangerous is that to us over the long run?
Well, that would be a significant concern. I mean, a mild elevation in CK might be okay because that might be coming, Larry, from your skeletal muscle, right? Which is, of course, the big source of CK. It's a muscle enzyme. Of course, it's in the heart, and so the specific marker of heart damage is, of course, troponin I or troponin T. So if you're exercising and your troponin levels, are going up, you need to see your cardiologist. Okay, they should not be. What type of exercise are you doing? Like riding your bike, going for a brisk walk?
No, for example, like my son was just playing an hour of basketball, and he had elevated troponin one time, and then elevated CK levels. That put him into the hospital for a few days because it went up to 2,500 for the CK. Yes. But I'm just wondering, have you ever, with Fabry patients, looked at how exercise does affect the heart with doing blood work, testing them for different types of exercise?
No, we have not done that, and that is a fascinating question, and we should do that in terms of what type of exercise program to recommend with patients with Fabry disease, right? So, and I think, I would certainly stay away from strenuous exercise because that would really put a burden on the microvasculature and give added stress to the heart. So things that I would do would be, mild to moderate exercise.
Okay, because for example, I swim with a club 3 times a week, and we on average do about 2,200 to 2,500 meters an hour. And Dr. Iwanachko has said to me, that has also strengthened my heart. Yes. But I would like to know, because my heart is very strong, although I have a defibrillator pacemaker, right. My heart is very strong. But obviously my heart has been affected from Fabry. So, I'm trying to see what is the good balance here for patients with Fabry disease, exercise, and trying to keep the heart strong, but also not injuring the heart while doing so.
Right. So again, wonderful that you're swimming. It's such a great exercise. So I think that mild to moderate and just a repeated exercise, right? So doing it regularly is so important, right? Not only for Fabry disease, but just your general health in general, to be fit and so on. So certainly keep up with that. Of course, if you're having symptoms, things like chest pain, shortness of breath, you're feeling like you're going to have a blackout spell, of course, those would be reasons to stop and have them checked. But I take it you have not had elevation in your troponin levels?
I don't think I've ever had my troponin levels elevated. My son has, but I don't think I've ever really had it monitored to see if they do go up.
Well, and that's wonderful you brought it up, because we do have some funding now in which we are going to look at biomarkers in patients with Fabry disease. So we're going to work with Mike West, Mark Ivanachko, and his medical genetics colleague in Toronto, Chantel. And we're going to do it here in Alberta. So it's going to be a wonderful collaboration, and I hope you agree to be part of that, because we'd love to have a blood sample, a few blood samples over time, and to see how things change. I think that's why we need to look. So your your son may be a bit more affected because of the excellent condition, right? So he really needs to see Mark. Has he seen Mark?
Yeah, he sees Mark on a regular basis.
Okay. So I mean, his Fabry's disease might just be a bit more advanced, unfortunately. So he just needs to be a bit more careful.
Yes. Okay. Thank you so much. And by all means, I'll definitely give my blood. Whatever you need.
Thank you. Okay, great. So the next few slides, as we try to finish this up, I want to talk about, patients with hypertrophic cardiomyopathy, and so they can get misdiagnosed, and so we are seeing these patients actually having Fabry's disease. So these are older study. The numbers are probably high. It's probably 1 to 2%. Is what we're doing when we do this proper screening studies, but there are studies out there showing a fairly high prevalence of Fabry's disease in patients with hypertrophic cardiomyopathy, okay? This is a recent study with some very key players in the hypertrophic cardiomyopathy world, Robert Desnick, Christine Seidman, and so on, Barry Maran, and they picked this up in 2 families that thought that all along, for many decades, thought they had hypertrophic cardiomyopathy. And I know the Toronto group, hypertrophic group, has shown very similar findings too. So these were 2 families with multiple family members, 8 individuals with Fabry's disease that were basically missed because people thought they had hypertrophic cardiomyopathy, okay? So I think screening patients with hypertrophic cardiomyopathy, Fabry's disease is very important. Obviously, it's not an academic exercise because if you detect it, you can monitor, treat it, and so on. This is a wonderful study, probably the best study out there, 10-year study, prospective, multi-center study that looked at patients, over 2,000 patients that were studied, and they looked at from different specialties, from neurologists, because you can get stroke syndrome, from cardiology, of course, you can get heart disease, from nephrologists, of course, because you can get kidney disease, you can get eye findings, and all those specialties they looked at. And they were able to pick this up in 2% of patients, okay, that had Fabry's disease. 2/3 of those patients had heart findings, okay? So the cardiac involvement was the most common, okay? So you can get neuropathy, as you can see there, and kidney findings and eye findings. So those are also common with Fabry's disease, as most of you know. But again, the cardiac findings, the heart was involved in about 2/3 of those patients. Okay, so a very important thing to take seriously. So this is our paper. This is coming out tomorrow in PLOS ONE. We screened Fabry's disease in patients with unexplained hypertrophy. We did this in 266 patients in Edmonton and Hong Kong. We detected Fabry's disease in 2%. So in 5 patients, we found Fabry's disease. This was all the Hong Kong, the Hong Kong Taiwanese mutation. And interestingly, in one patient, a female patient, we actually found hydroxychloroquine cardiomyopathy. So some of you probably heard this name in a setting of COVID-19, but it's also being used to treat things like arthritis and lupus. It can poison the lysosomes, which is how it works, and it can lead, in patients that are susceptible, it can lead to a Fabry's-like phenotype. So we have now detected this in 4 women with hypertrophy. Of course, women here because they tend to have the arthritis and the lupus and the autoimmune problem. So we see it in women. So this is a big problem. Luckily, hydroxychloroquine did not work for COVID-19 because this was going to cause a huge problem with heart problems. Not only a cardiomyopathy, it also prolongs your QT interval and causes arrhythmias. Okay, so once again, we're able to detect in a young woman that showed up with LVH, and we're screening this young lady for Fabry's disease. Turns out she actually had hydroxychloroquine, and we actually had to do a biopsy of her heart, and it shows hydroxychloroquine-induced cardiomyopathy. All right, so it does look, we call it a phenocopy like Fabry's disease. All right, so it's an important finding to have. All right, I just want to finish up with therapies, right? So you guys are all excited, has been excited about enzyme replacement therapy. We know it works, especially when you start it early. And that is just wonderful to be able to have that enzyme replacement therapy. The two versions of this, Fabrazyme and Replagal, they both work in terms of improving cardiac and renal outcomes. And they're available for you guys, intravenous infusions, of course, every 2 weeks. As Lori was suggesting, managing risk factors, staying healthy, and exercise and so on are also very important, okay? So your overall health is important, exercise, appropriate diet, blood pressure control, that's a very key one, right? And we use ACE inhibitors for that. And for patients with Fabry's disease, we should be targeting the SPRINT trial guidelines. So your blood pressure should be as low as possible, less than 120. You do not want to give any extra stress to your heart, okay? So you can also tell that to your loved one, not to give you any stress, right? There we go. Say that Fabry's disease is affecting me. I do not need any more stress. But joking aside, your blood pressure should also be less than 120, okay? So as low as possible. So we have used angiotensin receptor blockers, ACE inhibitors to really control blood pressure. And we're seeing very good outcomes in our patients with that. All right, so blood pressure control, controlling lipids, controlling diabetes, and exercise, and all that is important. ACE inhibitors, angiotensin receptor blockers are also very protective on the kidneys. So they're very important drugs to use for cardiovascular and renal protection. All right, so this is again more data suggesting that when you use enzyme replacement therapy very early, we have this now from large registry, that your heart disease really stabilizes, okay? And in fact, in some patients, it can reverse. All right, so make the diagnosis, start the therapy early. Okay, that's pretty clear cut now, and I can tell you, even ahead of these papers, the current thinking is clearly in support of that all over. I mean, this is a global story now. This is a global opinion. Therapies should be started early. Okay, so that's the biggest impact. In addition to enzyme replacement therapy, you guys all know about chaperone therapy with megalostat. Again, some reversal of hypertrophy. Of course, if you have a mendable mutation, and in Alberta, we have about half our mutations are mendable. In Halifax, unfortunately, that mutation is not amendable to chaperone therapy. But so this is a therapy that's available for patients with Fabry's disease. Again, from our data that we've seen in the last 3 years, if you start this very late, you're probably not getting a lot of benefit. Okay, you also need to start this therapy very early. So I think that's a take-home message for all the rare diseases, Fabry's disease being no different. So as we're coming up with new therapies, we need to start them earlier, okay, to have the best benefit. And again, I just want to finish up and again, thank you all for being part of our studies, our biomarker studies, our imaging studies. I've shown you some of the work we have done and published would not have been possible without you guys. We're now doing a big biomarker study that's going to include Halifax, Toronto, and Edmonton and Calgary. Okay, so I hope you'll all be part of this, and you know, I want to thank you guys for being part of this. So in Alberta, we also provide care for patients in Saskatchewan, northern BC, and sometimes all the way out to Manitoba. So so we are also, patients do take the trip and to see us in Edmonton and Calgary. So we tend to coordinate those visits. They get the cardiac MRI at the same time and they see us in the clinic at the same time. So we'll also continue our screening program for Fabry's disease because we even if it's 1 to 2% of hypertrophic cardiomyopathy is no longer academic, we have therapies, okay? And a misdiagnosis is terrible because, as you know, 3 to 5 family members are going to be affected with Fabry's disease. So detecting it is important, treating it is important because we now have effective therapies, 2 major classes of therapy, enzyme replacement therapy, and chaperone therapy. So I just want to finish by acknowledging all our great colleagues here in Edmonton, the Mazankowski Alberta Heart Institute, the CK Wu Heart Center, Royal Catholic General Hospital, colleague Neil Brass, who we work closely with, our colleagues in Calgary with the wonderful collaboration we've had over the last decade, and good support actually from our industry partners, Sanofi Genzyme and Takeda, as part of an academic industry collaboration. So I think much of our research work would not have been possible without that type of funding. And again, it would not have been possible without your participation and being engaged and being part of the cure, part of the progress, and part of what makes this very exciting to be taking care of you guys and your heart disease with Fabry's disease. So I'll stop there.
Well, thank you so much. You are such an engaging person to listen to. So thank you for that. And really great information. I really like that you touched on the prevalence of Fabry, because I think that that's something that's new and coming with newborn screening. And really interesting to know that it's a lot more common than originally thought.
Right. And I think we need a follow-up study to, I think what the newborn study screening has done, and I think most provinces have them in Canada, most parts of the developed world has them, and so it has shown us that these conditions are way more common than we think, right? What's rare may not be so rare.
Yeah.
Right? And so we just need to follow those kids and see what's going on and how they're changing. And if they are having overt Fabry's disease, get them on therapies. And
absolutely. I really appreciate you talking about that as well, and we've had some questions about it, but I think early treatment is so important, and I really do agree with that. We've had a couple of questions about what would you say is early? What age is there? I know it's really hard to say an age, but what would you say for a male?
I would think as young adults, I would think in your 20s is when you would start. I mean, we have 3 or 4 patients here in Edmonton that have been started a bit late, in their 40s, late 40s, and unfortunately their Fabry's disease had progressed, and so they started a bit too late. The hypertrophy was there, the fibrosis was there, and they started late because that's when the drug was approved, right? I believe in 2001. In 2001, or right around then.
Yeah, around then, yeah.
Yeah, and so that's now as time is on your side, right? As we now have the therapies on board, we know they work. So as we're detecting the disease, we can now start treating it early, right? So I think it's only going to get better for patients with Fabry's disease.
Yeah, I think so too.
Yeah.
Someone was wondering, for those with a pacemaker,
Mm-hmm.
do they do CT scan instead of MRI?
Well, the CT scan, again, would have limited evaluation of the myocardium. You can do some CT PET studies that may show things like inflammation and fibrosis. But again, the MRI is probably the best method for that. Now, as you know, we now have MRI-compatible pacemakers and defibrillators.
Do we have those in Canada as well?
Oh, yeah, all over Canada. In fact,
we do. Okay.
Most pacemakers and defibrillators that are going into patients now are MRI-compatible. And they do them because the thinking is that these patients may need an MRI down the road. So you do not want to prevent them from having an MRI.
Great.
So
yeah.
There's no reason to be an advocate for an MRI because having a pacemaker or defibrillator no longer prevents you from getting one. So your MRI and followed by echo are still the best test. The CT would be something else that you might consider.
Okay. Now, it's Fabry disease. Fabry patients often have low blood pressure. Are you able to explain a little bit about why that is?
Well, it's probably a combination of things. I mean, Fabry's patients tend to be younger, right? So you may be in your 20s and 30s when you don't really see elevated blood pressure. And so young women with Fabry's disease, especially young women, you may have systolic blood pressure of 100 to 110 in that range. That's not on, but again, you know, let me say that that is actually a normal blood pressure for a young, healthy woman, right, in her 20s, and not just premenopausal blood pressure for women. There's also some autonomic neuropathy that you can get, and you can get some orthostatic changes in your blood pressure, which makes it a bit challenging to use things like ACE inhibitors, angiotensin receptor blockers, things like water pills, and so on. But you know, we have managed to get patients on ACE inhibitors and angiotensin receptor blockers, at least to low doses, maybe to moderate doses, without without causing without giving them too much of a headache in terms of managing their symptoms. So yeah, I mean, blood pressure can be low normal. Some of that is expected because we're dealing with young people, especially in young women, where blood pressures might be, systolic blood pressure might be, that's the top number, might be 100 to 110. So some of that is not unreasonable, but usually you can manage it and deal with it accordingly.
Okay. Yeah, someone was just asking, when we actually had this on our last call too, do you recommend taking an aspirin every day, or children's aspirin, or what are your thoughts on that?
So if you have Fabry's disease with no complications whatsoever, no. So that was the recommendation. So we have large studies now that have come out, mainly not in the Fabry's world, but in the cardiovascular world, with patients at risk for cardiovascular disease. And the data for aspirin for primary prevention is minimal. Okay? So for secondary prevention, pretty standard stuff to use, but for primary prevention, unless you're super high risk and you're male, you really have no evidence for benefit.
Okay, great to know.
Yeah. So in Fabry's disease, if you have no vascular disease, your risk factors are minimal and things like that, you really should not be an aspirin. Because in those trials, they also showed a significant bleeding risk. It's still small, but it's a significant bleeding risk.
Okay.
And the bleeding risk can be gut. It could be, for young women that are premenopausal. It could be heavy menses. I've seen young women have really bad, sorry to bring it up, really bad menstrual period to the point they're very anemic. Hemoglobin's in their 80s and 90s, and they feel terrible, and no energy. And so aspirin is doing harm, right, in that situation. So it's not only a tummy and ulcers and GI bleeding, it can also be menstrual blood loss and anemia, which is just not good. It's just harmful. So the evidence for it is actually quite weak. So most of us, I don't prescribe them now to low-risk patients. Other risk factors are important. Smoking, quitting smoking, very important. Fabry's is a vascular disease, so you do not want to have any other insult to your vascular system. So lipids, lipid control of diabetes, and smoking cessation, if you're a smoker, are absolutely critical. Okay, so you just don't want to have any other stress to the vasculature and also to your heart. So controlling blood pressure, quitting or reducing smoking, treating dyslipidemia, high cholesterol, keeping your diabetes under control, preventing diabetes by exercising. Those are all important things, right? So as we focus on Fabry's disease, we can't forget the basics.
Yeah,
right?
great. And to go with that, is there any health supplements like magnesium that we should be taking?
No evidence for any health supplementation. It's zero. The only evidence that we have health supplementation does well for patients is probably folate supplementation for women at childbearing age. That's like probably the only, and even that is somewhat controversial, right? That's really the only evidence. You know what? Health supplements, you know what they produce? One of my senior colleagues told me this. It produces expensive urine because you pee it all out, right? So it makes expensive pee. It does no good. In fact, it does. There's evidence for harm. Vitamin C is harmful. Vitamin E increases your cancer risk. Some of the omega-3 supplements that you get off the shelf, no good. Very expensive. That's a very expensive one. No benefit from that. So all the studies, unfortunately, are just not, no evidence for benefit. Again, a balanced diet, rich in fruits and vegetables. As you all know, the Canada Food Guide changed its recommendation last year, right? We're all aware of that. And it's a very pro-fruit, pro-vegetable diet. So that's the kind of diet we want to be consuming, a healthy heart diet based on the Canada Food Guide. Okay?
Yeah, I mean, this is actually one of the questions too, is that people are asking about diets. And for example, you know, there's so many different diets right now. There's a keto, which is a high-fat diet. Is there?
Absolutely. So diet is important too, because with Fabry's disease, you can get GI involvement. And I've seen a number of patients that have serious GI problems, right? So I think having the right diet, I think high fiber is important, fruits, vegetables. The ketogenic diet is just a fad. It's going to go away. In fact, the data suggests it's harmful. It's coming out, okay? So unfortunately, our body did not evolve to handle fat and meat and grease. That is not what we evolved to handle, okay? We are fruits and vegetable eaters. And that's what we really should be consuming more and more of, okay? So no special diet, just a Canada Food Guide, healthy heart diet, a diet rich in fruits and vegetables.
Perfect. Great message. Now, someone is asking in Canada, this is to go back to about early treatment. So in Canada, we have to qualify to receive ERT or therapy. So we should, so we do not all get treatment. Can you please address that issue? So I guess we're just wanting you to talk a little bit about the treatment guidelines.
Right. And fair enough. It's an expensive therapy. It's about $200K a year, and so people need to be rationed, and so there are criteria. I'm part of the CFDI guidelines, which is what we use to determine treatment. But if you have 2 organ involvement, you should, and the well-defined criteria, you should be getting enzyme replacement therapy. And if you have an amendable mutation, you may get the chaperone therapy. There are options. There's a third choice that's coming on board. It's substrate reduction therapy, SRT. Those are in phase 2 trial. So if that's positive, you may have a third group of therapies on board for Fabry's disease. But do see your medical geneticist. Do be an advocate for your condition. And we are, of course, advocating for you guys all the time. So more and more early therapies is what everybody's pushing for. The data supporting that is coming on board. It's not as strong as we would like, but the data is certainly supporting early therapies. So I think more and more it's going towards that. I think it certainly would help if things become a bit cheaper, right? Then it can be used a bit more widely. So, but yeah, be an advocate with your doctors, cardiologists, your medical geneticists, and the Fabry's Association, of course, for early therapies. But I think we're all on board, and I think everybody's thinking along that those directions.
Okay. Is there? Oh, sorry, I just missed my spot here. What percentage of Fabry patients will develop diabetes, or is there any studies in this?
Not directly that I know of. I can't. The risk really would be lack of exercise, right? It would be secondary to behavioral changes because of the sweating issue, right? And hydrosis, intolerance to heat, some of the pain and neuropathy and heart problems may make you less active. But as like Lori said, we should all be swimmers. So even if your legs hurt and things like that, or you have arthritis, you can still go swimming. So that's a good substitute exercise. If you can't run, if you can't ride your bike, swimming is a very good, especially as you get a bit older. It's just such a good exercise to get into. It really keeps you going. So yeah, so it may put you at risk by because you just can't exercise as much as you like, but there is no direct link to diabetes and Fabry's disease.
Okay. Could you maybe talk about, so have you ever looked at VO2 max when patients exercise? And if you know how this behaves and changes over time?
Yeah, so that's another important question. The VO2 max is really used mostly for specialized testing. So it's called part of a CPET, cardiopulmonary exercise testing. So we have done that in a few of our patients that we're sending for heart transplant assessment. So we do a VO2 max and we looked at gas exchange and things like that because it's just a more objective, better measure of your exercise capacity. Okay, your overall cardiopulmonary fitness, as opposed to how long can I exercise on the modified Bruce protocol, right? How long can I go on the treadmill? 5 minutes, 15 minutes? Doing the VO2 max is a more complex way of doing that, but we typically only do that in patients going for more advanced testing. Typically, if you start thinking about a heart transplant, and that is something we're contemplating in 2 of our patients right now, because the heart disease have gotten so advanced and they do not have problems in other organs. So heart transplant becomes an important measure. And so the VO2 max in those patients, measuring it and keeping track of it is very important.
Do you know if it improves when patients are on therapy versus be naive?
I'm less certain about that. But I can certainly look into that and look at that. I'm not aware of a study that have looked at a VO2 max readout in response to enzyme replacement therapy. But I can certainly look into it.
Okay.
It's typically used though in patients with advanced heart disease, where we really want to start thinking about heart transplantation.
Okay. Now, I think might be our last question. Thank you so much for answering all these. These are wonderful. And thank you to everyone for your participation and asking such great questions. How aggressive Fabry can damage the heart? As in how quickly the damage can progress? If major damage can happen over a year or 2 period. So yeah, I guess how quickly can this happen?
Well, it can happen quickly, and we know that now because we're studying children. And we're studying adolescents with Fabry's disease, and you can see changes in even adolescents. Some early hypertrophy, early fibrosis, and certainly as you hit early adulthood, you can really pick up these changes. Okay, so it's not the 40, 50-year-old that have progressive heart disease, it's the early stage, and that early stage is when you want to start therapies, right? So that's equally important, that you think about the early changes, detected cardiac MRI is your technique to go with, subtle fibrosis, subtle hypertrophy, lower T1 values, those are all important findings. And if you're starting to have those findings and somewhere else affected with Fabry's disease, you need to start on enzyme replacement therapy. So it probably starts in adolescence. You probably are going to detect these changes probably in an early adulthood, okay? So by the time you're 18 to 20 sort of thing range. So.
Okay, well, thank you so much. You gave us a lot of great information. Everyone is saying that in the group chat as well.
Okay.
If you could leave us, you said a lot of great things. If you can leave us with just one thing that you think that we should know about the heart that we can take home with us, and do, maybe it's exercise, whatever you think, what would your one piece of advice be to all of us?
Well, take your heart seriously, eat well, exercise, and bug the hell out of your cardiologist. Don't leave them alone, and you want to know what's going on with your heart on a regular basis. Be empowered. Most of you are empowered. You guys are an example to us of how you can how you can be engaged and be empowered and really understand your disease. You motivate us to do better and better, and to show up and provide your best care. And some of that, of course, is supporting all our research activities, because it's now improving care, like MRI and chaperone therapies and enzyme replacement therapies. So I think continue to be empowered, continue to ask questions, be engaged with your cardiology team, and the future is bright. The future is bright for Fabry's disease. Great.
Thank you very much. You did a wonderful job. Thank you so much.
Thank you all for joining. Have a great evening, everyone.
Nice to see everyone.
Same here. Okay. Bye-bye.
Bye-bye. Take good care.
Bye-bye.